Welcome to the Head, Neck, and Spinal Trauma Lecture. Topics today include epidemiology of injuries, anatomy and physiology, mechanisms and their associated injuries, brain injuries, intracranial pressure and autoregulation, patient assessment targeted at injuries towards the head, neck, and spine, and treatment of the aforementioned injuries. Before we begin, I'd like to cover some stats and talk to you about how trauma to the head, neck, and spine has impacted my family. If you guys already read your chapter, you know that head, neck, and spinal injuries are common with major trauma. In fact, approximately 4 million people experience a significant head injury each year, with 1 in 10 requiring hospitalization. Severe head injury is the most frequent cause of trauma-related deaths. Specific mechanisms of mention include auto crashes, gunshot wounds, and sports injuries. Populations most at risk include infants and young children, the elderly, and males between the years of 15 and 24. One of these males was my cousin Connor. The benefit of Camtasia is recording over and over again, and I have recorded this multiple times now and can't seem to get through this part all the way, but we're going to do the best we can. Connor was 18 years old at the time, and he planned to become a firefighter paramedic with 2 of his friends. Him and I were both the same age and both interested in this career path. In June of 2008, things drastically changed for him. Connor and his friend dove into a lake as they had done many times before, but this time Connor didn't come back up. When Connor hit the bottom, he suffered a spinal injury and had drowned. His friend, who finally realized something was wrong, pulled him out of the water, did CPR, and was able to revive him. Connor was airlifted from the lake and coded multiple times en route to the hospital. There, he was found to have a C4, C5 spinal injury. However, his injury presents as a C1 injury. This means that Connor relies on a ventilator to assist with his breathing, as he can't do so on his own. It also means he has quadriplegia, or no use of his arms and his legs. While his brain is fully functioning and he's still cognitively there and still my cousin, his body is no longer able to send and receive messages like yours and mine does. During his 4-month hospital stay, the doctors told our family multiple times that Connor would not be able to make it. When he finally was released, the doctors gave him a max of 10 years, but told us to fully expect to be back within the month. This June, we celebrated Connor's 10+1 anniversary. The past 11 years, Connor has not been back to the hospital once. He has traveled across the country to see places he has always wanted to see. He's used special equipment that attaches to his chair to sight in his own gun and successfully shoot a deer with my dad. He keeps in contact via Facebook, as he can do so on his own. And he has my brother be his arms while he creates all sorts of recipes because he loves to cook. They even created a Facebook page where he tours around Spokane and rates restaurants according to how accessible they are and their food. My cousin was that 1 in 10. He fits the criteria of most common cause of trauma-related death, as he did die, but he was brought back. And he is living with long-term disability. So with that, I asked Troy a few programs ago if I could teach this lecture, so here I am. While I know this is everyone's least favorite part, it's important to have a basic understanding of the anatomy and physiology of the head, neck, and spine. So that's where we're going to start. Rather than listening to me drone on or read out of the book, I've made and collected some videos to provide you insight and visual aids. Hopefully this makes it a little more bearable. The head is composed of 3 structures: the scalp, the cranium, and the meninges. Each of these components provide protection for the brain. The following video provides a real view of different layers of the scalp. Remember, scalp can be used as a mnemonic to help you remember the order of the layers of skin. S, skin. C, connective tissue. A, aponeurotica. L, layer of subaponeurotica or areolar tissue. And P, periosteum.
This is a quick demonstration of the layers of the scalp. So we have made a cruciate incision and we are going to reflect the layers of the scalp to show you how the scalp is oriented. Let's start with the classical teaching. SCALP. S, skin. C, connective tissue dense. A, aponeurosis. Aponeurosis. L, loose areolar tissue. Loose areolar tissue. Loose areolar tissue. And P, the pericranium or the periosteum. So we have the 5 layers of the scalp. Let's take them one by one. So let's make a quick mention of S, that is skin. The skin is hirsute. It's got multiple hair follicles, as you know very well, and it also contains sebaceous and sweat glands. The sebaceous glands produce sebum, which gives the natural oiliness to the skin. That is about the skin. Therefore, it's prone to a whole lot of skin problems, namely folliculitis. Now let's come to the next layer. C, the connective tissue dense. We can see part of the connective tissue dense layer here and we can see part of it here. This is the layer which glues the skin to the underlying aponeurosis and it forms a very tight connection and we had to dissect it out separately. So that is the connective tissue dense layer and we can see some blood vessels running in the connective tissue dense layer and this has to be dissected out very meticulously. Then we have the A, aponeurosis. This is the inner surface of the aponeurosis on this side and this is the aponeurosis on the other side and we can see this, as the term implies, is an aponeurotic expansion. It is also referred to as the aponeurosis of the occipitofrontalis muscle. It is also called the galea aponeurotica. This is an aponeurosis between 2 muscles. A muscle in front and we can see that muscle here. We can see that muscle here also. The front muscle is called the frontalis muscle. And the muscle at the back, which we cannot see in this dissection, is the occipitalis muscle. So therefore, it's an aponeurosis between the frontalis and the occipitalis. That's why it is also referred to as the epicranial aponeurosis or the occipitofrontalis aponeurosis. This aponeurosis, as it goes laterally, becomes a thin membrane and we can see that thin membrane here. In some books, it is referred to as the superficial temporal fascia. And in the superficial temporal fascia, we have running the superficial temporal artery and the superficial temporal vein and we can see part of that here. And as it goes further laterally, it gets attached to the zygomatic arch. So we can see the lateral expansion of the galea aponeurotica. But that is not called the galea aponeurotica, neither is it called the aponeurosis. It is the superficial temporal fascia. Some surgical books it is also called the temporoparietal fascia. That is about the aponeurosis. The occipitalis muscle is originating from a line on the back of the skull which is referred to as the superior nuchal line and it gets inserted onto the galea aponeurotica. When it contracts, it makes the galea aponeurotica taut and tense. The frontalis muscle, which we can see here, it takes origin from the galea aponeurotica and we have cut it here to show the origin. This is the beginning of the origin of the frontalis muscle. We can see the frontalis muscle here also. And it gets inserted by intermingling with the fibers of the orbicularis oculi here and it also intermingles with the fibers of another muscle, that is the procerus muscle, which we can see here. Therefore, the insertion of the frontalis muscle is not to the bone but it is to the skin. That is going to play a significant role for us later on. When the occipitalis muscle contracts, it makes the galea aponeurotica taut and it increases the functionality of the frontalis muscle. And then the frontalis muscle, when it contracts, it produces horizontal wrinkles on the forehead. So that is the role of the galea aponeurotica. The first three layers, namely the skin, the dense connective tissue, and the aponeurosis, we have lifted up all the three layers together on this side, and this is what is referred to as the scalp proper. The loose areolar tissue is this layer which I mentioned earlier. This loose areolar tissue has got plenty of clinical significance. This is very poorly vascularized, and therefore infection can spread very rapidly in this layer. The next important point is that many emissary veins pass through this space, and they communicate on the scalp on the outside and with the intracranial venous sinuses inside the skull. And therefore, they are routes of spread of infection and can produce intracranial venous thrombosis. That is another important clinical correlation. The third important clinical correlation pertaining to this loose areolar tissue layer is that when there is a blunt trauma to the head or to the scalp, the emissary veins can bleed, and then the blood can track down all the way. The blood cannot go posteriorly because the occipitalis muscle is attached to the superior numeral line. The blood cannot go laterally because the superficial temporal fascia is attached to the zygomatic arch on both the sides. The only place that the blood can go is anteriorly, and it does go anteriorly, and we can see it here. It tracks under the frontalis muscle, and it spreads all around the loose skin of the eyelid. The eyelid skin is very loose, and that's what produces what is known as the black eye or the raccoon eye. That is another important clinical correlation pertaining to the loose areolar tissue layer. This is a clinical picture of a child with blunt head trauma to show the black eyes, the periorbital ecchymosis. And this is a picture of a raccoon, the animal with black eyes, to show why it is called raccoon eyes. And finally, there are many instances on record where the long hair can get caught in a machinery and the whole scalp can be avulsed from the rest of the skull, and that is referred to as the avulsion of the scalp. Just to give you a historical point, in the mid-19th century, the Native Americans used to scalp their enemy, and they used to cut the scalp in this layer and they used to take it off as a trophy, and that scalping was done. Of course, they did not know about it, but this was done in the loose areolar tissue layer. So these are some of the clinical significance of the loose areolar tissue layer, and it is also postulated that this loose areolar tissue layer can also be partially protective. When there is a blunt trauma to the head, the scalp moves, and therefore it partially absorbs the blow of a blunt trauma to the head in the loose areolar tissue layer. So that is about the clinical and the functional significance of the loose areolar tissue layer. Again, let me reiterate, the loose areolar tissue layer is not strictly speaking part of the scalp proper, because as I have already mentioned, the scalp proper is the skin, the dense connective tissue, and the aponeurosis. The lateral margin on this side can be clearly seen. And finally, the periosteum or the pericranium. The periosteum or the pericranium closely invests the skull, and it goes through the sutures between the skull bones as a sutural membrane, and it communicates through the foramen of the skull as well as the foramen magnum, and they become continuous with the periosteum on the inner surface of the skull, which is referred to as the endosteum. This periosteum, especially on the base of the skull, when it becomes the endosteum, is tightly adherent to the base of the skull. So whenever there is a fracture of the base of the skull, the endosteum and the periosteum, they tear and then can lead to CSF leakage, which can come out through the nose when it is known as CSF rhinorrhea, or it can come out through the ear when it is known as CSF otorrhea. So these are some of the clinical significance of the layers of the scalp. Since we have already dissected it out, let me show you some of the muscles which are already visible. I have already alluded to this muscle here that we can see, and this muscle on this side. This is the frontalis muscle, which I told you takes origin from the galea poneurotica and gets inserted onto the subcutaneous tissue of the eyelids on both the sides. And this is the one which is responsible for producing horizontal wrinkles on the skin of the forehead. That is the frontalis muscle. The next muscle that we can see here, we cannot see it so clearly on this side, but we can see it more clearly on this side, is this muscle. This is the procerus muscle. This is the one which gives the disdainful appearance of the face when it wrinkles this portion of the face. This is the procerus muscle. The third muscle that we can see here are these fibers. We can see some of these fibers here. This is the orbicularis oculi. This is the palpebral part of the orbicularis oculi, which is over the eyelid. And this is the one which is responsible for gentle closure of the eyelid. and the surrounding fibers around it, these are the orbital part of the orbicularis oculi, which is responsible for tight closure of the eyelid. So we can see these three muscles in the dissection of the scalp. And finally, before I conclude, I have already mentioned it before, this is the lateral extension of the gallia aponeurotica. Surgical textbooks call this the temporoparietal fascia, while anatomy textbooks call it the superficial temporal fascia. This is of surgical implication to the plastic surgeon. They use it for various reconstructive procedures, and therefore it is also referred to as the subcutaneous musculo-aponeurotic structure of the face. And running in this layer, we have the superficial temporal artery, part of which we can see, and the superficial temporal vein, and the auriculotemporal nerve, which we have not dissected out yet. And finally, under that will be the true temporalis fascia or the deep temporal fascia, which also we have not yet dissected out. So these are the various layers of the scalp. Thank you very much for watching. Dr. Sanjay Sanyal signing out. If you have any questions or comments, please put them in the comment section below. Have a nice day.
The next video reviews the cranium and facial bones. The cranium is strong and does a good job protecting the brain. However, if a force is great enough to impact the brain, the cranium becomes the brain's worst enemy by locking in its contents. When the brain begins to bleed or swell, there's no room for it to move, so it begins to displace its contents, which increases intracranial pressure. Sometimes when this occurs, the brain ends up herniating or moving downward through the foramen magnum.
The human skull is made up of 8 cranial bones that surround and protect the brain, and 14 facial bones that form the underlying structure of the face and support for the teeth. With the exception of the mandible, the bones of the skull articulate with each other through joints known as sutures. Throughout the skull, holes known as foramina serve as passageways for blood vessels and nerves. Bones on the surface of the skull encase the brain, protect sensory organs, and serve as attachment sites for the muscles of the head and neck. These bones include the occipital bone, parietal bones, temporal bones, and the frontal bone, as well as the nasal bones, the zygomatic bones, the maxilla, and the mandible.
Beneath the cranium lies 3 layers of connective tissue called the meninges. These help protect the brain and the spinal cord.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the meninges. The term meninges comes from the Greek for membrane and refers to 3 membranes that surround the brain and the spinal cord: the dura mater, the arachnoid mater, and the pia mater. The meninges protect and provide structural support for the brain as well as contain cerebrospinal fluid. The outermost layer of the meninges is the dura mater, which literally means hard mother. This thick and tough layer adheres to the skull on one side and the arachnoid mater on the other side. The dura provides the brain and spinal cord with an extra protective layer, attaches the brain to the skull and the spinal cord to the vertebral column to keep them from being jostled around, and provides a system of venous drainage through which blood can leave the brain. The arachnoid mater gets its name because it has the consistency and appearance of a cobweb. It is much less substantial than the dura. Strands of connective tissue called arachnoid trabeculi stretch between the arachnoid and pia mater. These help to suspend the brain in place. Between the arachnoid and pia mater, there is also an area known as the subarachnoid space, which is filled with cerebrospinal fluid. The pia mater is a thin layer that closely follows the contours of the brain. It forms a tight membrane around the brain and spinal cord, acting as an additional barrier and aiding in the secretion and containment of cerebrospinal fluid. Blood vessels are held against the pia mater by connective tissue before they penetrate the brain. There is a space between the dura of the spinal cord and the bone of the vertebral column known as the epidural space. Analgesics and anesthesia are sometimes administered here. Also, the dura and arachnoid mater extend several vertebrae below the end of the spinal cord, creating a cerebrospinal fluid-filled area called the lumbar cistern, where there is no spinal cord present. Cerebrospinal fluid can be withdrawn from here because a needle can be inserted with little risk of damaging the spinal cord. Thus, the lumbar cistern is the site where cerebrospinal fluid is aspirated in a lumbar puncture, also known as a spinal tap. This is done, for example, to diagnose meningitis, a potentially life-threatening inflammation of the meninges.
Following along with the last video, underneath the arachnoid membrane lies the subarachnoid space. This is filled with cerebrospinal fluid, which is clear in color and contains water, protein, and salt. It is produced in the largest ventricles of the brain and helps by cushioning the central nervous system and absorbing shock. Now we've reached the brain. The brain can be divided into three parts: the cerebrum, cerebellum, and the brainstem. The cerebrum is the largest portion of the brain. It makes you, you. It's responsible for consciousness, thought, personality, speech, motor control, vision, hearing, touch, and perception. Looking at this picture, you'll see that brain has gray matter and white matter. The gray matter is on the exterior cortex and contains cell bodies. Most of the inside of the brain contains white matter, which controls communication pathways called axons. The brain has 4 regions and 2 hemispheres. The frontal region controls personality. The parietal region controls motor, sensory activities, memory, and emotion. The occipital region controls sight. The temporal region contains long-term memory, hearing, speech, taste, and smell. The hemispheres are divided by the falx cerebri. There are a right hemisphere and a left hemisphere. Interestingly enough, each hemisphere controls the opposite side of the body. The left hemisphere is dominant in most people. It's responsible for things like math, writing, language, and speech. The right hemisphere, or non-dominant hemisphere, processes images. Posterior and inferior to the cerebrum is the cerebellum. Having trouble remembering which is which? Cerebellum has an L for little and lower. The cerebellum helps with balance and fluid movement, as well as muscle tone. The video you're about to watch covers the brainstem. The brainstem only accounts for 2% of the total body weight, but it receives about 15% of cardiac output and consumes 20% of the body's oxygen supply. One other concept worth mentioning when we're talking about the pons is the ascending reticular activating system. This system is a tract of neurons within the upper brainstem, pons, and midbrain. It's responsible for the sleep-wake cycle. It also plays a large role in regulating things such as respiration, heart rate, and peripheral vascular resistance.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the brainstem. The brainstem is a stalk that leaves the base of the brain and connects the brain to the spinal cord. It contains many important pathways that run between the brain and spinal cord, as well as pathways to other areas like the cerebellum. It also contains a large number of important nuclei and is essential for both survival and proper cognitive functioning. It consists of 3 major divisions: the medulla oblongata, the pons, and the midbrain. The medulla oblongata, often simply called the medulla, is the point where the brainstem connects to the spinal cord. The medulla is essential for survival, as it contains nuclei that ensure vital systems like the cardiovascular and respiratory systems are working properly. The medulla also contains nuclei that are responsible for a number of reflexive actions, including vomiting, swallowing, coughing, and sneezing. Several cranial nerves also exit the brainstem at the level of the medulla. The next structure on our way up the brainstem is the pons. The word pons means bridge in Latin, and the pons is a large, rounded structure resembling a rounded bridge that connects the medulla and the midbrain. The pons is home to a number of nuclei for cranial nerves and contains nuclei that deal with sensations from the head and face, motor movement of the eyes, face, and mouth, hearing, equilibrium, and autonomic functions like tear and saliva production. The final branch of the brainstem as we move toward the cerebrum is called the midbrain. On the posterior side of the midbrain we find 4 bumps representing 2 paired structures, the superior and inferior colliculi. The superior colliculi are involved in eye movements and visual processing, while the inferior colliculi are involved in auditory processing. The midbrain also contains the major dopamine-producing nuclei of the brain, the ventral tegmental area and the substantia nigra. Among other functions, the ventral tegmental area is involved in motivation and reward, while the substantia nigra plays an important role in movement.
Blood is supplied to the brain by 4 main arteries, 2 internal carotid arteries, and 2 internal vertebral arteries. At the base of the brain is the circle of Willis. The internal carotid arteries and basilar arteries meet here. From here, smaller arteries branch off and feed the rest of the brain blood. The next video discusses cerebral perfusion pressure, intracranial pressure, and the Monroe-Kelly doctrine.
Monroe-Kelly Doctrine by Dr. Lisa Del Signore.
So the first thing I'd like to talk about is the principles behind brain swelling in terms of the Monroe-Kelly doctrine, which you may be familiar with. Essentially, this doctrine states that the cranial compartment is incompressible, so the volume inside is a fixed volume. There are 3 things inside the cranium that make up its volume: brain tissue, blood, and CSF. Because the volume is fixed, these 3 things maintain an equilibrium such that when the volume of one component increases, the volume of another decreases. For example, when a lesion such as an epidural hematoma adds to the brain volume, there are compensatory decreases in CSF and venous volume, as you can see here. However, at a critical point, the CSF and blood buffers are not able to compensate for changes in cranial compartment volume. That is, when the volume increases too much, usually at volumes greater than 100 to 120 mLs, the intracranial pressure begins to rise as well, as you can see here. At this point, the intracranial pressure begins to skyrocket with changes in intracranial volume. And what we're trying to prevent here is reaching that critical point where brain swelling increases so much that the intracranial compartment is unable to maintain its pressure. And this is important because the amount of intracranial pressure that we see is directly related to the cerebral perfusion pressure, which is the driving pressure the brain is seeing in terms of delivering oxygen and other key nutrients to it. And cerebral perfusion pressure is defined as the equation, as you can see here, mean arterial pressure minus the intracranial pressure. So for any constant mean arterial pressure, you can see that as the intracranial pressure starts to rise, your cerebral perfusion pressure starts to drop, which means that the brain will start to see less nutrients, less oxygen, which can have deleterious effects on the brain in terms of ischemia and cell death. And typically when we talk about managing cerebral perfusion pressure, we think about minimum targets by age. And we'll get into this in a little bit in a few minutes. But you can see here that less than 4 years of age, we try to target a cerebral perfusion pressure around 50 millimeters of mercury. Anywhere between 4 to about 10 years of age, we target around 60 millimeters of mercury as a minimum target. And greater than 9 years, we start to think of them more as like an adult and target cerebral perfusion pressure around 70 millimeters of mercury.
Going back to the head and the skull, we're going to pick up where we left off in a video and discuss the facial bones.
Other bones become more visible only when looking inside the skull. The sphenoid bone makes up the anterior base of the cranium. It is a butterfly-shaped bone with a central body and 2 pair of laterally projecting wings. These wings form portions of the orbit. The body of the sphenoid features a depression known as the sella turcica, which houses the pituitary gland. Located between the orbits, the ethmoid bone makes up a portion of the cranial floor and also the roof of the nasal cavity. An inferior projection, the perpendicular plate of the ethmoid bone, forms part of the nasal septum. The crista galli projects superiorly from the ethmoid bone and serves as the attachment point for the falx cerebri, a dural fold. Extending laterally from the crista galli is the cribriform plate, a perforated area through which the olfactory nerves pass. The 2 L-shaped palatine bones form the posterior third of the hard palate, part of the nasal cavity, and a portion of the orbit. The small, thin lacrimal bones make up the anterior portion of the medial wall of each orbit. A groove known as the lacrimal groove helps to form the nasolacrimal canal, which contains a duct that allows tears to travel to the nasal cavity. The vomer is an elongated, plow-shaped bone that forms the inferior and posterior part of the nasal septum. The internal and external skull bones articulate precisely, forming an intricate structure perfectly suited to its functions.
The next two videos you're going to watch cover the anatomy of the ears and the eyes.
The human ear is made up of three parts: the outer, middle, and inner ear. The outer ear consists of the pinna, which serves as protection for the delicate inner parts of the ear, and the external auditory meatus, the ear canal, which collects sound and directs it towards the eardrum. The shape of the pinna also helps to detect where sounds are coming from in the vertical plane, that is, from above or below the ear. The middle ear is an air-filled cavity located in the temporal area of the skull. It consists of the eardrum, the tympanic membrane, the ossicles, and the eustachian tube. The tympanic membrane is concave with an area of between 60 and 90 millimeters and an average thickness of just 0.07 of a millimeter, and it has a very rich blood supply. Sound waves enter the ear canal and strike the tympanic membrane, setting it in motion. The louder the sound, the more the membrane moves. The middle ear also contains three small bones, known as the ossicles. These are connected in a chain across the middle ear, from the tympanic membrane to the entrance of the cochlea, called the oval window. The ossicles are called the malleus, the hammer, the incus, the anvil, and the stapes, the stirrup. The handle of the malleus is attached to the tympanic membrane, and the base of the stapes, known as the stapes footplate, sits loosely in the oval window of the cochlea, held in place by the annular ligament. The tympanic membrane vibrates in response to sound. The eardrum moves the malleus, which in turn moves the incus, and then the stapes, the footplate of which moves in and out of the oval window and transfers the energy to the endolymph fluid in the cochlea. The inner ear has two distinct portions: the vestibular portion, concerned with balance, and the auditory portion, the cochlea, which is concerned with hearing. The vestibular portion is made up of three semicircular canals. Each canal has a swelling at one end, the ampulla, and two membranous sacs, the utricle and the saccule. These contain fluid and sensory cells, which move in response to head movements and travel to indicate the body's status. The vestibular system works in conjunction with the eyes and the receptor cells in the joints of the body to continuously maintain our balance. The cochlea appears as a coiled tube in the shape of a snail shell, with between 2.5 and 2 3/4 turns. It is wrapped around the acoustic portion of the auditory nerve. If we were to unravel the cochlea, it would be about 35 to 40 millimeters long. It is split into three distinct sections, known as the scala vestibuli, scala media, and scala tympani. The scala vestibuli and the scala tympani contain perilymph fluid. The scala media contains endolymph fluid. The Reissner's membrane separates the scala vestibuli from the scala media, and the basilar membrane separates the scala media from the scala tympani. Along the basilar membrane are two types of sensory cells, or hair cells, called the outer and inner hair cells. These are arranged in their rows according to the frequency or pitch of sound they detect, and covered by the tectorial membrane. Each hair cell has tiny hair-like projections, called stereocilia, attached to them. When sound energy is transferred to the cochlea, the basilar membrane vibrates up and down, causing the outer hair cell stereocilia to shear on the tectorial membrane above. This shearing action causes the stereocilia to bend, which opens the ion gates, leading to chemical changes and a resulting electrical charge inside their cells. These charges make a neural impulse, which travels along the auditory nerve to the brain and which is interpreted as sound. This complex mix of physical, chemical, and mechanical processes occurs almost instantaneously and creates our perceptions of the sounds we hear in everyday life.
What are the parts of the eye? The eye is arguably one of the most complicated organs in our body. It is unique in its ability to transmit light rays and images through the pupil, focusing them clearly through the vitreous humor and onto the retina, and finally converting it into electrical signals that are carried to the brain via the optic nerve. But what are the basic parts of the eye that provide this ability? Let's find out. The cornea. The clear bulging surface in front of the eye is the cornea. The cornea helps us see in a number of ways, including being the primary refractive surface of the eye, being the eye's primary defense against foreign debris and irritants. Tears also help the cornea maintain its hydration, antibacterial integrity, water content, and extensive oxygen exchange. The iris. The iris is the pigmented color portion of the eye. The iris's abilities include a sphincter muscle that controls the amount of light allowed into the eye through contraction and dilation, similar to a camera aperture. The pupil. The pupil is a hole approximately 3 to 7 millimeters in diameter through which light passes. The natural lens. The eye's natural lens has the ability to change shape as one focuses on nearer distant objects. As one ages, the lens becomes less flexible, leading to presbyopia. This condition is the reason why people look to use bifocal glasses or reading glasses. The vitreous. This is the clear gelatinous substance that fills the space between the lens and retina. This fluid helps to maintain the eye's shape. The retina. The retina is a layer of tissue at the back of the eyeball, acting like the film of a camera for the eye. It contains cells that are sensitive to light, both black and white as well as colored. It converts these light stimuli into electrical nerve impulses and sends them to the optic nerve. The optic nerve. The optic nerve is bundled at the back surface of the eye. Electrical nerve impulses travel along the optic nerve and onward to the brain. The entire eye. With a better understanding of the eye and its structures, one can appreciate its true complexity. Taking sight for granted is easy to do. However, it is easy to see and appreciate the true complexity of the eye. For more information on this and other eye-related topics, visit our blog at blog.contactlensking.com or subscribe to our YouTube channel.
For those of you who are thinking, Courtney, you haven't taught us anything yet. We're literally just watching videos right now. You're right now you are. But there isn't a good way for me to lecture on anatomy. The best way for you to learn is to visualize the portions of the body as they are being discussed. These videos are able to do just that. So bear with me and know that there's a method to my madness that's not just pure laziness. While the neck is relatively small, it contains several important structures. As we've talked about before, the neck is often left vulnerable to trauma. In the military, law enforcement, and now even the fire and EMS world, we have protective gear for the head and the chest, but the neck is relatively unprotected. Its essential structures can also make it a target in assault. When blunt trauma has a significant force, the neck can be easily injured, even if at the musculoskeletal level. The neck contains both the carotid arteries and the jugular veins. The carotid arteries can be found by placing your 2 fingers over the trachea and moving horizontally into the groove, like we do when we're checking a carotid pulse. They are paired in a sheath with the internal jugular veins and the vagus nerve. The external jugulars, which may be used by the paramedic for vascular access, are found on each side of the trachea. I'm not going to go into detail about the airway structures of the neck, as you guys had airway last quarter and you're in the midst of your clinical intubations, so you guys should be solid there. I'm also not going to go into detail about the cranial nerves, as Dr. Hodges covered this in depth last quarter, both in lecture and in lab. I do want to go over a few other neck structures with you, though. The thyroid gland surrounds the superior portion of the trachea, just under the cricoid cartilage. This butterfly-shaped gland controls your metabolic rate and calcium levels. Another structure worth mention is the brachial plexus. This is a group of nerves that control the arm to the hand. When we talk about trauma to the neck, we typically divide the neck into 3 zones. Zone 1 is below the cricoid ring. These have the highest mortality rate, and after reviewing the anatomy, I'm sure you can guess why. Zone 2 is above the cricoid ring, but below the angle of the jaw. More common, but less protected area. This often involves the carotid arteries or the larynx. And Zone 3 is above the angle of the jaw. Here we're concerned about cranial nerves. Now that we've discussed the head and the neck, we will move on to the spine. As we've discussed, there are 33 vertebrae working together to provide the structure and framework of our bodies. If anyone is going, wait a second, I thought there were only 26. You're kind of right. We start with 33, but by adulthood, 9 of them fuse together to form the sacrum and the coccyx. This leaves 26. 24 separate vertebrae, then the sacrum and the coccyx, each counting as 1. The lower the vertebrae, the more weight it bears, which is why there is an increase in size as we move downward. Although different, the vertebrae share common features. Compare and contrast the vertebrae as you watch the following video.
So we have 4 vertebrae here. We have a lumbar vertebrae, a thoracic vertebrae, and then 2 cervical vertebrae. And we're going to talk about the different features that are common to them all, and then some of the features that specific vertebrae have. So the first feature we're going to talk about is the body. And so on the lumbar vertebrae here, you can see we have a very large body that is used for supporting weight. As we go further up the vertebral column, we get to the thoracic vertebrae, and we can see that the body here is a little smaller. Now, these didn't necessarily come from the same vertebral column, but nevertheless the pattern is similar. When we come to the cervical vertebrae, here on axis, we can see that the body is even smaller than the thoracic vertebrae. By the time we get to C1, Atlas, we can see that there is no body, and it's thought that in development that the body of Atlas moved down to C2, and this is it here, and this is called the orthodontoid process, or more commonly known as the dens. Next we're going to look at the spinous process, and the spinous process are those ridges that you feel up and down your back. So with the lumbar vertebrae, you can see that this is the spinous process here. With the thoracic vertebrae, we have the spinous process here. And part of the features of the thoracic vertebrae is that the spinous process is hooked, or it angles down from the level of the vertebrae. By the time we get to the cervical vertebrae, we can see that here is the spinous process, and it is bifurcated, which means it's split, and all of the cervical vertebrae, their spinous process is bifurcated except for C7. Here on Atlas, we can see we don't really have much of a spinous process. Next we have the transverse processes. So on our lumbar vertebrae, our transverse process is here. On the thoracic vertebrae, we can see that we have the transverse process here. Then on C2, our transverse process are on each side here. And we can even see that we have these foramen on each side, and these are called transverse foramen, and they are unique to the cervical vertebrae. So how you define a cervical vertebrae is by the transverse foramen. We can see on Atlas, we have the transverse foramen here. The hole that the spinal cord runs through is called the vertebral foramen. So we can see it here on the lumbar vertebrae, here on the thoracic, and it's quite obvious on Axis and Atlas. We also have superior and inferior articulating facets. So if we take a look at Atlas here, we can see that the superior articulating facets articulate with the occipital condyles and allow the head to go in the movement of yes. And the inferior articulating facets are here. Now on Atlas, these facets are horizontal, they're more in the plane of the bone. As we move down to the thoracic vertebrae, we can see that here we have our superior articulating facets, and if we turn it over, here we have the inferior articulating facets, and these are in a much more vertical plane than we saw when looking at the facets on Atlas. On our lumbar vertebrae, we can see that we have the superior articulating facets right here, and the inferior articulating facets are right here. There is also this part of the vertebrae here, which is a little foot where the processes join on to the body, that these are called the pedicles. So we can see it right here. And then the spinous process is made up of the lamellae that fuse on each side. Oh, don't. So also, we have the vertebral notch right here, and if two vertebrae are placed together, they form the intervertebral foramen. So we can see, well, that's not a very good one. We can see here that we have the intervertebral foramen right there. If we look at the lumbar, we can see the intervertebral foramen there. And holding the vertebrae like this, you can also see how the superior and inferior facets articulate together. So between the vertebrae, we have the intervertebral discs, which are a cartilaginous joint, but yet between the articulating facets here, this is a synovial joint.
The vertebral column is divided into 5 sections: 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccyx. There are a few things I want to point out at each level, starting with the cervical spine. This portion of the spine is the sole support for the head. C1 is called the atlas and has no spinal process or vertebral body. While you may not care about Greek mythology, remembering that Atlas was the Greek titan who is forced to support the heavens on his shoulders may help you to remember that C1 carries the head on its shoulders, or its facets. C1 allows the head to nod in the yes motion. C2 is the axis. It is the strongest portion of the cervical vertebrae. Its defining feature is the odontoid process, or the dens. This allows the head to move from side to side. To help you remember this, C2 allows you to see from side to side. The last cervical vertebrae is C7, which has a distinct spinous process. When palpating the spine, it is the first bony prominence and located just above the shoulders. Moving down, we meet 12 thoracic vertebrae. As I said before, the lower we get, the bigger the vertebrae are, so the body of these vertebrae are much larger. The spinous and transverse processes are also larger and contain demifaucids that articulate with the ribs. These allow movement of the thoracic cage during respiration. It's important to note that T1 differs from the rest of the thoracic spine in that it has both a full faucet for the first rib and a demifaucet for the second rib. The lumbar have the largest vertebral bodies. The intervertebral discs separating these bones are also the largest as they carry the most weight. There's also the most movement here. The sacrum has 5 vertebrae that are fused together and form the posterior wall of the pelvis. These help protect the urinary and reproductive organs. The coccyx plays no major function. In between each vertebrae are the intervertebral disc. The exception is the atlas and the axis, and the sacrum and the coccyx. 25% of height of the spinal column comes from these discs. This is where geriatrics lose their height. The intervertebral discs play an important role in protecting the spinal cord. They also absorb shock and cushion the vertebrae. Within the foramen of the vertebral column is the spinal cord, which carries messages from the body to the brain and vice versa. In a fetus, the cord runs along the entire spinal column. However, as we grow, spinal cord growth slows down. By adulthood, the spinal cord stops at L1, possibly L2. Past L1 or L2 are peripheral nerves contained within a dural sac. These are collectively known as the quada equina. The spinal cord itself is fed blood through the anterior spinal artery and 2 posterior spinal arteries. In the event that there is damage to these arteries, the spinal cord will become hypoxic, just like any other tissue. As a result, your patient may present with signs of spinal cord injury, which we will discuss later. The following video discusses the intricacies of the spinal cord.
So first we'll take a look at the ascending pathways. So we'll look first at the dorsal columns, which convey fine touch, proprioception and vibration sense from the periphery up to the brain. So you've got the fasciculus gracilis, which I've highlighted in yellow, and you've got the fasciculus cuneatus. So just remember that fasciculus means small bundle. So the fasciculus gracilis carries information from the lower limb, so it has axon fibers from the lower limb, whereas the fasciculus cuneatus has fibers from the upper limb. So the way I remember this is that the letter C is before the letter G in the alphabet, so C is higher and your upper limbs are higher than your lower limbs, so fasciculus cuneatus carries fibers from the upper limb, whereas fasciculus gracilis carries fibers from the lower limb. Now how do you remember which one is medial and which one is lateral? So in yellow we've got the fasciculus gracilis and in green we've got the fasciculus cuneatus. And how to remember this is that your arms are lateral to your legs, and you know from the previous mnemonic that the fasciculus cuneatus carries fibers from the upper limb. So because your arms are lateral to your legs, the fasciculus cuneatus is lateral to the fasciculus gracilis in the spinal cord. So next we've got the spinothalamic tracts. So these I've just highlighted in blue. And the spinothalamic tracts are also known as the anterolateral tracts, as they sit anteriorly and laterally in the spinal cord. and some texts will refer to distinct anterior and distinct lateral tracts, but almost invariably there is some intermingling of fibres between the anterior and lateral tracts. So on this diagram they're represented as one tract. So the anterolateral tract is known as the spinothalamic tract, and this relays information to the somatosensory cortex regarding pain and temperature information and also crude touch. So the lateral aspect of the spinothalamic tract carries pain and temperature, whereas the anterior spinothalamic tract fibres carry crude touch information. So the next descending pathway is that of the spinocerebellar pathways. So I've highlighted these both in purple and lighter purple. So you've got the dorsal and ventral spinocerebellar tracts. So these tracts relay information from muscle and joint receptors to the cerebellum, and these tracts are examples of the pathways which carry subconsciously processed information, whereas the dorsal columns, the fasciculus gracilis and the fasciculus cuneatus, and the spinothalamic tracts carry consciously processed information which is processed in the somatosensory cortex. So these spinocerebellar tracts don't carry information that is consciously processed, so they don't have the 3 neuron sequence which are described in the previous part of the tutorial. So basically you've got information coming via these tracts from muscle spindles and Golgi tendon organs, and this information is relayed to the cerebellum and allows for the control of posture and to coordinate muscular movements. So now we'll take a look at the descending tracts. So these descending tracts start in the cerebral cortex and brainstem and descend down the spinal cord to innervate muscles. So they are involved in controlling movement, muscle tone, spinal reflexes, and also have an ability to modulate some of the sensory information which is brought up via the ascending tracts. So essentially the ascending tracts bring in information from the environment relating to sensory information, and the descending tracts carry information from the center, the brain, to act in response to this sensory information. So it's useful to think of these descending tracts as pyramidal or extrapyramidal, and pyramidal just refers to tracts which pass through the medullary pyramids. So the pyramidal tracts are the corticospinal tracts. So you've got the lateral corticospinal tract and the anterior corticospinal tract, which I've highlighted in orange. So the corticospinal tracts are important to know about because they convey voluntary, skilled movements originating from the motor cortices of the brain. So the lateral corticospinal tracts carry motor information destined for the limbs, and it's important in skilled voluntary movement. The ventral corticospinal tract carry axial motor information. So the axial muscles are those central muscles which aren't limb muscles essentially. So you may start to notice the significance of the naming of these tracts. So remember the descending tracts we talked about, the spinothalamic tracts and the spinocerebellar tracts. You'll notice that the first part of the name of the tract relates to the first where the tract begins, and the second part of the name of the tract relates to where that tract ends. So spinocerebellar, it starts in the spinal cord and it projects to the cerebellum, and then spinothalamic starts in the spinal cord, projects to the thalamus. So you know that they are ascending tracts. And now we've just talked about the corticospinal tract, so starts in the motor cortex and projects down into the spinal cord. So it's a descending tract. So there's always clues and hints in the names. So just to cover some of the extrapyramidal tracts, you've got the rubrospinal tract, which I've highlighted in red. So this originates in the red nucleus of the midbrain tegmentum and is responsible for limb flexors. And then you've got the tectospinal tract, which I've highlighted in light purple here. So it's seen here kind of intermingled with the medial longitudinal fasciculus. But the tectospinal tract originates from the superior colliculus of the midbrain. So the clue's in the name again. So the tecto part of this word refers to the tectum, which consists of the superior colliculus and the inferior colliculus. So fibres from the tectospinal tract mainly terminate in the cervical segment of the spinal cord and carry information responsible for movements in response to visual sensory information. And then we've got the vestibulospinal tract. So this is highlighted in bright pink, and this originates in the vestibular nuclei in the pons and the medulla. So you've got a lateral vestibulospinal tract and a medial vestibulospinal tract. So highlighted here is in pink is the lateral vestibulospinal tract. So the vestibulospinal tract receives information from the bony labyrinths and the cerebellum relating to balance and posture, and this pathway allows for the control of extensor motor neurons in order to maintain posture. And then lastly, we've got the reticulospinal tract, which arises, as the name suggests, from the reticular formation of both the pons and the medulla. So you've got a medial or ponto-reticulospinal tract, which is the one highlighted here in green. And then you also have the medullary reticulospinal tract, which aren't shown here, but I'll just draw them on the rough location of these fibres. So you'd have the medullary reticulospinal tract fibres in this region here. So that's the lateral reticulospinal tract. And this tract, the reticulospinal tract, is responsible for reflexes, muscle tone, and is also involved with the respiratory and circulatory system. So that's an overview of the different ascending and descending spinal cord tracts.
Now in this video we're going to go through the spinal nerves. So very quickly I want you to remember that the peripheral nervous system, meaning the nervous system that comprises of all the nerves that come out and away from the brain and the spine, and all the nerves that come back in towards the brain and the spine, that's what we refer to as the peripheral nervous system. Which again means that you can have nerves that come from the brain and to the brain, and nerves that come from the spine and to the spine. And today we're just going to talk about those nerves that come into and out of the spine, and we call those spinal nerves. So if we were to have a quick look, I've drawn up the spinal cord here, and what I've done is I've drawn every single spinal nerve that comes out and in to the spine, and what you'll find is that there are 31 pairs. Now I've just drawn one side, but you can picture this as being mirror imaged on the other side. Now if we break this up, we can break it up similarly to how we do when we look at the vertebrae of the spine. So remember, you have cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral vertebrae, and coccygeal vertebrae. Well, it's the same when we look at the spinal nerves. Okay, now there's only one small difference. So remember when I told you, how do you remember the numbers of vertebrae associated with each particular region? I said, remember the times in which old people tend to eat. What times do old people tend to eat? They tend to eat at 7 a.m., 12 p.m. and 5 p.m. 7 a.m., 12 p.m., 5 p.m. Which means that there are 7 cervical vertebrae, there are 12 thoracic vertebrae, and there are 5 lumbar vertebrae. And the sacral and coccygeal vertebrae, well, they are individually fused together, so don't worry about that. So when we translate that to the spinal nerves, 7, 12 and 5, well, it's exactly the same except there's one difference. Instead of there being 7 cervical nerves, there are 8. And the only reason why that's the case is if you think about having 1, 2, 3, 4, 5, 6, 7 cervical vertebrae, if we have a look at the cervical nerves, one comes out the top and then the rest come out underneath. So if you were to count that, you have 1, 2, 3, 4, 5, 6, 7, 8 cervical nerves, even though you only have 7 cervical vertebrae. Now when we look at the remaining, so when we look at the thoracic vertebrae, there are 12, and there are also 12 thoracic nerves. When we look at the lumbar vertebrae, Well, there's only 5, and there's also 5 spinal nerves. So the only difference you need to remember is that of the cervical nerves. Alright, now that we've stated that, and you can see I've summarized it here on the left-hand side, what I want to go through is the different spinal nerves and where they innervate, so where they go to, and also something called a plexus. Now, some of these spinal nerves, when we look at them, when they come out and away from the spine, they actually come together and form a bundle. And this bundle will branch out again at some point, and what we call that is a plexus. Okay? So a plexus is a bundle of nerves that will branch back out again. So I want to show you the 4 main plexuses of the spinal cord. And yes, that's the plural of plexus, it's plexuses. Let's have a look. So the first plexus that you need to know is what we call the cervical plexus. Makes sense, okay? The cervical plexus, which is made up of the cervical nerves C1 down to C4. So these nerves here, C1 to C4, they branch out of the spine and then they come together to form a bundle. And like I said, this bundle will branch back out again. Now, what do we call this bundle? We call this bundle the cervical plexus. Okay? Now, the cervical plexus needs to go somewhere, needs to innervate some part of the body. Now, the place that this innervates is the back of the head, the neck, the shoulders, and also the main one that I want you to remember, the diaphragm. Now, there's a number of different nerves associated with the cervical plexus, as you can see, but there's only one that I want you to remember. The nerve that I want you to remember, it's associated with the cervical plexus, is that nerve that innervates the diaphragm. And that nerve is called the phrenic nerve. The phrenic nerve innervates the diaphragm. Now, why is this important clinically? Well, think about individuals who have been in, let's say, some sort of motor vehicle accident in which they may have severed their spine, or a particular portion may have had a hemilesion of the spine. Somewhere in C1 to C5, this may affect their ability to breathe because it may have damaged that phrenic nerve. And that phrenic nerve innervates the diaphragm, which you know is a muscle that is the barrier between the thoracic cavity and the abdominal cavity. And this diaphragm is in a dome shape, and when you innervate it and tell it to contract, it contracts downwards and you breathe in. Okay? So if that nerve's damaged, it's going to affect breathing. Okay, what's the next plexus I want to talk about? The next plexus is the one that we call the brachial plexus. And the brachial plexus is C5 to T1. That's the brachial plexus, which means that cervical nerve 5, 6, 7, 8, and thoracic nerve 1 come together again to form a bundle, and we call this bundle the brachial plexus. Now, this brachial plexus, where does that innervate? Well, what's brachial mean? Brachial means arm. Remember, that's the region that the brachial refers to. So these nerves innervate the arm. Let's write that down. Innervate the arm. And what's the nerves that I want you to remember? Well, the nerves that I want you to remember, there's 3 of them. I want you to remember the radial nerve, the ulnar nerve, and the median nerve. The radial nerve, the ulnar nerve, and the median nerve should be pretty easy to remember, because if you have your arm down like this, you know that you have the radial bone, the radius, right? That's the one closest to the thumb. How to remember that? Your thumb can move in a circle in a radius. Therefore, the bone closest to that's going to be called the radius. And the ulnar bone, which is on the other side. Therefore, the radial nerve is the nerve closest to the radial bone, the radius. The ulnar nerve is that closest to the ulnar, and the median nerve is the nerve that goes down the middle. Okay, so you need to remember those 3 nerves. Clinically, what is their importance? Let's talk about the radial nerve. There is something called Saturday night palsy, which you may or may not have heard. Some people go out, have a few drinks, get a little bit pissy, come home and fall asleep on the couch with their arm hanging over the edge of the couch. What this does is it impinges the radial nerve. Okay? It impinges on that nerve. And what that does is, well, the person wakes up with a dead arm. And that's what we call Saturday night palsy. What about the ulnar nerve? Have you ever hit what we call the funny bone? You get that tingling sensation down your arm? Well, that's when you hit that ulnar nerve. And what about the median nerve? Have you heard of something called carpal tunnel or carpal tunnel syndrome? This is where individuals have difficulty with moving, opening and closing their hand. And that's because that median nerve that goes down the middle actually goes in and innervates some of the fingers of the hand by going underneath a ligament. And this ligament is called the carpal ligament, okay? And it forms like a tunnel. So that median nerve has to go through that carpal tunnel. And therefore, if something happens with that nerve, and let's just say there's some damage to it, or it tightens up a little bit, well, it's going to impinge on the median nerve, and that's going to affect one's ability to use their hand, and that's carpal tunnel syndrome. So they're the three nerves of the brachial plexus that I want you to remember. What's the next plexus that I want to go through? The next plexus we call the lumbar plexus, and the lumbar plexus is L1 to L4, which again means that lumbar nerve 1, lumbar nerve 2, lumbar nerve 3 and lumbar nerve 4 come together, form a bundle, which again branch out again, and we call that the lumbar plexus. And the lumbar plexus will innervate the anterior aspect of the thigh, the medial aspect of the thigh, and the lateral aspect of the thigh, which is the front and the sides. Okay, so let's write that down. The lumbar plexus, anterior, medial, and lateral aspects of the thigh. What's the one nerve I want you to remember for the lumbar plexus? This is the femoral nerve. Femoral nerve. So if you were to have some sort of bulging disc at L2, for example, this may again impinge on some of these nerves here, L2 for example, and what that's going to do is affect the innervation down to the thigh and possibly alter one's ability to walk. And that's what we call an alteration in gait, G-A-I-T, gait. That's a way somebody moves, okay? So that's the lumbar plexus. The final plexus I want to go through, we call, surprisingly, the sacral plexus. And the sacral plexus goes from L4 to S4, which means that we have lumbar nerve 4, 5, sacral nerve 1, sacral nerve 2, sacral nerve 3, and sacral nerve 4 again coming together, form a bundle, which again branches out again. And we call that the sacral plexus. Now, where does the sacral plexus innervate? First, I want you to remember the lumbar plexus was the front and sides of the thigh. So, what's left? The back of the thigh, the posterior aspect. So the sacral plexus will innervate the back of the thigh. So let's write that down. Posterior thigh. And everything, it innervates everything below the knee. Okay? So let's write below knee. Now, everything below the knee, that's a lot, right? So the nerve that you need to remember is what we call, and I'm sure you've heard it before, the sciatic nerve. And the sciatic nerve, well, think about what if you had sciatica. Have you heard of sciatica before? So some issue with this sciatic nerve, what happens? Well, people get immense amounts of pain going from their butt down through the back of their thigh and into their leg. And sometimes this will stop an individual from being able to use their leg properly, and their foot tends to drop. And that's just called foot drop. Okay? And that's what happens if there's damage to this sciatic nerve or some part of this sacral plexus. So you can see the four plexuses of the spinal cord: the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. I've told you where it innervates, and I've told you the main nerves that I want you to remember for each of these plexuses. Now, you hopefully are asking the question or thinking, Why isn't there a plexus at the thoracic region? And the answer to that is, think about where would these nerves of the thoracic region, where would they innervate? Well, they would wrap around and innervate the ribs. So they would go through and innervate the intercostal muscles, and they would innervate the lower aspect of the abdomen. Okay? So the thoracic nerves, basically they come out and they innervate the intercostal muscles and the inferior aspect of the abdomen. Okay? And that is basically a quick run through of the spinal nerve. So I hope that was helpful.
Now that we've covered anatomy and physiology, we can dig into trauma with a better understanding of the impact certain injuries will have on the body. Since this is a two-part lecture, I'll start with some of the more basic injuries, leaving the more complex injuries for our in-class lecture, where I can answer questions and discuss the injuries more in depth with you. Let's start with the ears, specifically the pinna. Trauma to the pinna is often caused by blows, tearing, or avulsion. In this case, providers should attempt to place the pinna back in its normal position, then pad the area between the head and the ear to help maintain its position. The ear should be covered with a sterile dressing and secured in place. Injuries can also occur to the inner portion of the ear and impact hearing. In these cases, you may not be able to physically do anything for your patient's injury. However, you may be able to calm their nerves and reassure them that they will receive the help they need. Use creative methods to ask questions, whether it be a pen and paper or using your phone to type out to them. Ask them if their hearing is diminished or completely absent. Some may complain of a ringing noise called tinnitus. Injuries to the eye can be a little more complex. Eye tissue is specialized and does not regenerate well. There are several different types of injuries to the eye, but here are a few common ones. Hyphema is a condition where the eye is injured and hemorrhaging occurs in the anterior chamber. The blood may pool in front of the iris and the pupil. This condition is serious and could result in loss of vision. Another condition called subconjunctival hemorrhage occurs when the blood vessel in the subconjunctival tissue ruptures, resulting in bleeding. The provider will notice a portion of the eye is red. While it looks bad, this condition is actually less serious and typically goes away without intervention. Retinal detachment is as it sounds. The patient may complain a portion of their field of vision is blacked out, which is serious and concerning. For the above-mentioned injuries, there really isn't much we can do. The patient requires transport for expert consultation. Most eye injuries can be handled by bandaging the affected eye. When there is major damage, it's best to cover both eyes to prevent sympathetic motion. You should also cover both eyes when an impaled object is involved. Torn eyelids should include wet, sterile dressings. You can also apply an ice pack to reduce swelling and pain. If a patient complains of eye pain and there is no visible trauma present, assume there was an irritant. You can examine the eye by inverting the eyelid or by pulling down the lower lid. The patient may benefit from flushing of the eyes, either with water or using a nasal cannula with oxygen. Even after an irritant is removed, the patient may still complain of pain or discomfort. The patient should be placed in a supine position. Remember to ask patients if they have contact lenses in. These should be removed as soon as possible. Nasal injuries are pretty straightforward and rarely life-threatening. The nose is very vascular and can bleed both anteriorly and posteriorly. Anteriorly, there are a network of vessels called Kisselbach's plexus. For this type of bleeding, do your best to position the patient with their head forward to help avoid blood going down the throat. Place an ice pack on the patient's nose. That can help with the swelling and with vasoconstriction. You can also put one on the back of their neck. If the bleeding is posterior, it could drain down the patient's throat. If able, have them spit the blood out. Blood upsets the stomach and could lead to vomiting.